Hi, I'm David Beck, and I'm coming from the New York University School of Medicine, and I'll be talking today about how I diagnose Vexas syndrome, and it's really exciting to be here as part of the first International Vexas Workshop. So what is Vexas syndrome? So the V in Vexas stands for vacuoles that are often seen in the cells identified in the bone marrow, usually the early erythroid and myeloid precursors. E stands for E1 ubiquitin activating enzyme encoded by the gene UBA1, which is what is mutated in patients with Vexas. X because UBA1 is an X-linked gene. A because patients have auto-inflammatory symptoms. And S because the mutation is somatic or acquired in one's life. So Vexas syndrome is an auto-inflammatory disease caused by mutations in the gene UBA1. It causes systemic inflammation. It happens at a later age of onset, typically in patients that are over 50 years of age. It mainly affects men because the gene is on the X chromosome. And patients often have other clinical diagnoses, myelodysplastic syndrome, Sweet syndrome, even lupus, rheumatoid arthritis, yet they carry the UBA1 mutation and have symptoms that are atypical for their clinical diagnoses. So it's not just found in patients who are undiagnosed. And we don't yet have clinical and diagnostic criteria for Vexas syndrome, although the mutation is what defines the disease. Vexas causes systemic inflammation and hematologic disease. So the UBA1 mutations occur in the bone marrow, and they populate the peripheral blood. The bone marrow is the primary site of new blood cell production, and the blood stem cells produce the red blood cells and white blood cells and platelets, and they circulate throughout the body. And so the mutation is found predominantly in the white blood cells, the myeloid and neutrophils. And Vexas ends up affecting multiple different organs because of these immune cells. So the systemic inflammation can cause skin, painful rashes, inflammation of the cartilage, so this is chondritis, pain in the swelling of the ear and nose, inflammation of the lungs, exemplified by cough and shortness of breath, swelling and pain in joints or arthritis and arthralgias, and then inflammation of the vessels, so vasculitides. And just showing you here, this is a graphical depiction of all the different clinical features that should clue you in for when to test for Vexas for a UBA1 mutation. And so here's just highlighting these different clinical manifestations. Shown on the top are the pulmonary manifestations, pulmonary effusion, ground glass opacity shown on the CAT scan. In the middle panel in the top row, we have the alveolitis, the median vesicle vasculitis, and then the alveolitis. In the second row, we have the dermatologic, the skin findings and disease, so Sweet syndrome, injection site reactions, the neutrophilic dermatoses that you see in the histology in F. Inflammation of the cartilage in the third row, ear, nose, and also this periorbital edema. And then finally, in the bottom row, we have the hematologic manifestations of disease. So this is a PET scan showing highly activated bone marrow, and then the early erythroid and myeloid precursors with these big vacuoles. So the clinical spectrum of patients with UBA1 mutations, they can meet diagnostic or classification criteria for a variety of different clinical diagnoses. I mentioned this already, but these are things that should clue you in for potential Vexas diagnosis, is patients with relapsing polychondritis, Sweet syndrome, myelodysplastic syndrome, multiple myeloma, polyarteritis nodosa, and giant cell arteritis. So again, it's not that patients have no diagnosis, it's that they could carry these clinical diagnoses and others, but have some atypical features with inflammation and anemia. And here's just highlighting the clinical symptoms, not just the clinical diagnoses. So the demographics, usually age of onset is 64 years old, predominantly happens in men, although there are reports in women, fever, skin, lung, cartilage inflammation, and then the hematologic features. So macrocytic anemia is common within the disease, venous thromboembolism, so blood clots, and bone marrow vacuoles. So really the disease encompasses both inflammatory and hematologic manifestations. And so what I just showed you was work from the NIH cohort and NYU, but here we have data from the largest reported registry from France, in which they looked at very similar features and found a little bit of a different clinical spectrum, although highly overlapping. So again, the patients who have the UBA1 mutation in Vexas are predominantly men, although females are identified. The age of diagnosis, the median age is 71. And chondritis is present, skin lesions are present, but chondritis is much less common. They're also identifying lots of ocular inflammation. 40% have eye inflammation, lung inflammation, and also lots of cardiac involvement. So just to highlight, if there's suspicion for a clinical diagnosis of Vexas, there's a large spectrum of inflammatory manifestations that can occur, and hematologic manifestations, also thrombocytopenia, anemia, multiple lineages of low blood counts. So what is happening in Vexas? So Vexas is caused by acquired or somatic mutations. So just shown here in the slide, on the left are germline mutations present in every cell in the body. Those are the ones that are inherited or passed down. On the right are somatic mutations. Those are the acquired mutations that just occur within one cell type. And that's what UBA1 is in Vexas. It's a mutation that's only present in the blood, not in other tissues, acquired during life, and not inherited, so not passed down to the next generation. So what are we doing with genetic diagnoses, how we diagnose Vexas? Well, we now know that it's something that should not just be considered in patients who have ultra-rare presentations or undiagnosed. It's actually present in 1 in 4,000 men over the age of 50. So a significant number of individuals have this disease, and it should be considered. The penetrance is 100%, meaning that everyone that has the mutation has a phenotype. And the phenotype can be quite diverse, and now I'm just highlighting the different clinical manifestations that have been associated with UBA1 mutations in Vexas. So rheumatic conditions, hematologic conditions, pulmonary and cardiac, and then dermatologic. And so how do we make the diagnosis? So first we have to suspect that a patient has this diagnosis. So I've gone through some of the key features of the disease in terms of clinical manifestations. Another key feature is refractory inflammation requiring higher dose steroids and failure to respond to first-line therapies. And so the way we actually confirm the diagnosis once we have a patient we suspect is genetic testing. So genetic testing should be sent on all patients suspected of having Vexas syndrome, and a pathogenic mutation confirms the diagnosis. And I put here required because it's still a question of whether or not if you have symptoms that are very much in line with Vexas, you should carry the diagnosis without the mutation. But for now, the mutation defines the disease. The testing modality depends upon available resources. There are many different ways to test for Vexas. One of the ways is through targeted sequencing, just on the region where there's a highly recurrent mutation in this particular part of the gene called exon 3. And this can diagnose the majority of cases, although next generation sequencing, which has higher sensitivity, can identify low mutation cases or mutations outside of exon 3. So testing should only be sent on peripheral blood or bone marrow. It should not be sent on tissues outside of the blood compartment because the mutation is restricted there. So why does a genetic diagnosis matter? What does it matter to actually make this diagnosis? So it matters because we can provide better guidance for patients. So the median survival time for patients with Vexas is 10 years. So we can actually provide a little bit of prognosis in terms of their disease. We can also start to predict what therapies will work. I mentioned one of the salient features of the disease is that many times patients don't have effective therapies and don't respond to anything but high-dose steroids. And now clinical trials, international phase 2 trials have shown that JAK inhibitors like ruxolitinib are beneficial for disease. And we're excited to see that there will be more and more drugs in clinical trials coming out soon that will hopefully show benefit for Vexas. And the idea is that these drugs are not commonly used for the clinical diagnoses. So making the genetic diagnosis helps clue into treatments that wouldn't otherwise be used. So ongoing work. We as a community need to better define who to test, meaning instead of having this picture of the clinical manifestations, actually perform studies to look at the sensitivity and specificity of testing within populations of different diagnoses. And this will help provide guidelines. We also need to provide guidelines about how to test. Do we use one modality or another modality? What is the best modality to use? And emerging questions come with what mutations actually cause Vexas? All of us have mutations in our body in different cells, and it's unclear which ones actually cause disease or don't. And we now have a landscape of some mutations that clearly are pathogenic, but there are many that we're still trying to resolve. And treatment in clinical trials is obviously at the heart of all diseases. Better defining the disease, better defining who to test will help us be able to guide treatment. And I think there's a lot of ongoing effort to consider how best to treat this disease with clinical trials going forward. So just to conclude, the clinical phenotype of Vexas is predominantly in older individuals with hematologic and rheumatologic disease. It should raise suspicion for Vexas syndrome. Genetic testing is required for the diagnosis, either targeted, just looking at one region of UBA1, or whole gene coverage. You need to have a pathogenic or a likely pathogenic mutation in UBA1. And the most common site is methionine 41. So this is the hotspot mutation that defines Vexas. And then further work is required to delineate who, when, and how to test for this disease because most patients still remain undiagnosed. And with that, I just would like to thank you for your attention, and I hope that this was informative.